Hi, everyone. I'm Candice Chu, the third-year clinical pathology resident at Texas A&M University. Welcome to the fourth-year clinical diagnostic rotation. Today, I will be talking about the approach to cytology. So in the first week, we will be covering how to make blood smears. And then on Friday, it was supposed to be the hematology session, but I believe you have received the hematology assignments already. And today I'm going to cover the Monday of the week 2 section to focus on approach to cytology. And then Tuesday we'll be discussing several clinical chemistry cases. Thursday and Friday will be case presentation, and there will be a short quiz on Friday. So imagine yourself, you're a general practitioner working in the clinic, and there's a dermal mass on the dog. You perform the fine needle aspirate and you prepare several cytology smears. What would be your next step? So take a couple of minutes, a couple of seconds to think about that. All right. So when you have slides, essentially what you wanted to do is to stain them, right? But don't stain all of them. You pick maybe the most promising or the second to the most promising smear, put it in the diff quick stain to see if there are any cells on the slide. If there are cells, then that means you probably have a diagnostic sample, and then you can send the stained slide along with all the other unstained slide out for the pathologist review. In that way that you will not be wasting your client's money to send out non-diagnostic smears. And remember to stain just one of the smear, but not all of them, because pathologists do prefer our own stain in the lab. And even if we don't like your diff quick stain, sometimes we can restain it, but it is better that you submit on stain slides as well. All right, so this is our own stain, which is called Wright's stain. And basically the microscopic evaluation of the slide, starting when we look at the slide grossly. So among these 3 smears, these are all prepared from liver fine needle aspirate in a dog. Number 1, number 2, number 3, which slide would you pick to look at under the microscope first? So take a couple of seconds to think about your answer. All right, the answer would be number 3. And historically, students have thought that maybe number 1 would be the best one, or sometimes they think the number 3 would be the best one. And the reason is that when they look at the hemodilution, the blood contamination in the background, they feel like number 1, number 3 is more spread out, whereas number 2, you clearly see there's some thick area on the smears, and this you won't be able to see anything in this very, very thick area. And I think that's a very valuable reason. But the actual reason is that cells stain in different color in the right stain. So number 3, all the bluish basophilic area means there are a lot of cells. So I would definitely look at number 3 because it is very likely that there are a lot of hepatocytes in this area. So I'm going to show you a very extreme example in a very cellular cytology smear. Sometimes it can look like this. This is all blue. So every time when we see slide like this, we would put that under the microscope to take a look at first. So when you pick the slide, you put it under a microscope, you want to examine the cellularity in the low power, for example, like 4x or 10x objective. So by looking at this, I would say this sample is highly cellular. There might be a mild hemodilution because all the orange color, they are red blood cells. And then the next step is you want to go to higher magnification to actually identify the cells. And so once we go to the higher magnification, we actually notice that not all the cells are intact. So this is an intact neutrophil. This is an intact large lymphocyte. This is probably another intact large lymphocyte. And that's probably another intact large lymphocyte. And Many other cells, there are actually lysed cells. So you will only be able to see the nucleus and there's no clear cytoplasmic border around the cells. So I would focusing my interpretation only on the intact cells and try to ignore those lysed cells, or you will find a better location where you can visualize most of the cells and where most of the cells are actually intact. All right, and the other very important part is when you submit the sample, please provide a relevant history. So a lot of times I got unrelated history on the submission sheet. For example, like sometimes I only have rechecked, and I really don't know rechecked with internal medicine has anything to do with this dermal mass. So that is really not helpful. And then a lot of times I would get Cushing as well, but how does that relate to this dermal nodule? Still unknown. Or there are times I got liver sample and the history was abnormalities in the ultrasound. Yeah, I was like, thanks, but I bet that's why the liver got sampled, but I still don't know why. So I will appreciate a little bit more information in the submission. Also, the location has to be specified. So if you put abdominal mass, I would be thinking, is it in the abdomen or this is on the abdomen? Also, mass on the head is not super helpful because head is quite big and you have like different locations. It could be on the ear pinna or it could be on the nose, who knows? So be sure to specify the location. And then the other thing that would not be a problem in the teaching hospital, but when you graduate and work in the clinic, be sure that if you're submitting slides made from the fluid sample to specify whether this is a direct smear versus a concentrated smear. Because if you submit a concentrated smear, we take a look and we found that the cellularity is increased, and we thought you were submitting a direct smear, that would change our interpretation. That would change from the normal fluid to a inflammatory process because of the increased cellularity. So be sure to specify whether this is a direct smear or you have concentrated the fluid before making the smear. All right. So go to the main point of today's talk. We will be talking about approach cytology. And the reason why I want to teach this is to teach you a organization that can be applied to all of your future cytology samples. So when we talk about cytology examination, the first thing is to put it under the microscope in the low power to determine good cellularity versus poor cellularity. So the definition for cell is we're talking about intact nucleated cells. So red blood cells would not be considered as part of the cellularity assessment. And a cellular structures, there's really no nucleus, no cytoplasm. We would not include that into our cellularity assessment as well. So you can see here on top of the picture, you see a bunch of the cells, you see cytoplasm, you see nucleus. These are all intact nucleated cells. So this is definitely highly cellular with a very mild blood contamination, because all these more like dark pink, even to slightly brown color, round structure, those are red blood cells. Whereas at the bottom, this one, you see some structures that may look like cells, but there's actually no nucleus. So these are all keratinaceous debris. They are not really cells. So once you determine the sample has good cellularity, and the next step is to figure out whether this is inflammation versus neoplasia. And when we talk about inflammation, we are talking about several different types of inflammation: neutrophilic, eosinophilic, lymphocytic, macrophagic, and mixed type inflammation. So we are going to talk about each of them. And I will show you an overview picture here so you can appreciate their different morphologies. All right, so neutrophilic inflammation, also known as Yes, and also known as suppurative inflammation. And every time when we identify there's a neutrophil inflammation, we need to focusing on the neutrophil morphology to determine whether this is degenerate versus non-degenerate neutrophils. So here I'm showing you a abdominal fluid from a horse. These two cells are mesothelial cells. They're perfectly normal and common to see them in the body fluid. So just ignore them, but you can see a bunch of neutrophils in the background. So my question is, are these neutrophils degenerate or non-degenerate? It might be a little difficult for you to answer the question, but if you have another picture to compare with, and I think this is very obvious that we have non-degenerate neutrophil on the top, and then we have degenerate neutrophil at the bottom. So when we describe the morphology of the degenerate neutrophils, usually we talk about loss, hyposegmented, loss of segmentation, pale nucleus, swollen nucleus, and sometimes we describe that as a puffy Cheeto appearance. So going back to higher magnification of the cytology, that tells us what's the most likely, most common reason for seeing degenerate neutrophils in a cytology sample. And if you can see in the picture, there's some rod-shaped structure in the background, also inside the neutrophils. Yes, so that is septic inflammation, meaning the observation of seeing intracellular bacteria. But I understand that sometimes the concept of septic can be messed up with sepsis. So I will try to avoid using septic in my cytology report. I will just be focusing on using the term of presence of intracellular bacteria. And I think that makes it very clear to a clinician that I do see bacteria, and this is bacterial infection. All right, so there are several causes for neutrophilic inflammation in addition to bacterial infection. We can also see neutrophilic inflammation, for example, in immune-mediated situation. When you think about multiple swollen joint in an adult dog, that usually indicate immune-mediated polyarthritis. Also, think about chemical irritation. So where you will see chemical irritation, for example, like urine abdomen, burn, or bioperitonitis, those are neutrophilic inflammation. And also trauma, also necrosis. All right, then move on to eosinophilic inflammation. I think this is a type of inflammation that you're most familiar with. And usually students can think about some common causes. For example, like parasite is the obvious one. Fungal infection is another one. Also allergy, hypersensitivity reaction, paraneoplastic, especially in the mast cell tumor, also the T-cell lymphoma. And then something like fungal organism, but not exactly as fungal organism. So like Pythian or mycetes, they cause eosinophilic inflammation as well. And also don't forget the cause of idiopathic. And then moving on to lymphocytic inflammation. So in this picture, we have a type of neoplasia, and then we have lymphocytic infiltration. All the cells pointed by the arrows, they're all small lymphocytes. So common causes for that would be like viral infections. So think back to your pathology course. A lot of viral infection cause lymphocytic encephalopathy, encephalitis in the brain. And then also think about immune-mediated cause. For example, like IBD is usually lymphocytic, but can also be other cell types as well. And then macrophagic inflammation. So macrophagic inflammation can also be addressed as, yes, as histocytic. And also there is another term you might be able to use that's called granulomatous. Yes, very good. And there are several reasons for macrophagic inflammation. The most common one is still fungal infection. So think about all the possible fungal organisms that can be associated with macrophagic inflammation. Also foreign body reactions. Sometimes we talk about complex bacterial infection and what are those complex bacteria? Try to take a few seconds to think about them. Can you come up with any fungal complex bacteria? For example, mycobacteria, actinomyces, nocardia, those would be complex bacteria. And then there's also resolving or chronic inflammation that will be associated with macrophagic inflammation. So here's the picture of the macrophagic inflammation. You will notice that there are also presence of neutrophils in the background. And how do you know these cells are macrophages? Macrophages, the classic appearance would be they have abundant cytoplasm and they're very foamy. And another helpful feature would be you see them eating stuff. So for example, this cell is very foamy, abundant cytoplasm, and they're also stuffed in the cytoplasm. So making this cell very likely to be a macrophage. And can you recognize this structure inside the cytoplasm? This is hematoidin. When you see hematoidin, this diamond-shaped yellow crystals in the cytoplasm indicate the presence of previous hemorrhage. So there are evidence of previous hemorrhage in this sample. Because if it is a ongoing or recent hemorrhage, then you will see an intact red blood cell. If it's a previous hemorrhage, you will probably see hematoidin or hemosiderin in that case. All right, so here comes the first quiz. What type of inflammation is this one? And I want you to choose the best answer. Describe everything that's happening in this picture. Yeah, so you would choose either neutrophilic, lymphocytic, macrophagic, or neutrophilic and lymphocytic, or neutrophilic and macrophagic. All right, so pick your answer, write it down somewhere, and then we will be jumping to the next question. All right, the next section. So we have finished all the discussion about different types of inflammation. And for the next section, we will be talking about different types of fungal organisms. And I'll be showing picture asking you which fungal organism is this one. And please pay attention to the size and the morphology of the fungal organism. For example, this one would be quite small because you would notice this big thing is one monocyte or one macrophage. So these fungal organisms are quite small. Which one would be this one? All right. Then question number 3, which fungal organism would be this one? So considering the size of the cell, this is a huge multinucleated giant cell. So that's why this is so big. But you have individual fungal organism within the cells. And if you compare the size of the organism to the neutrophil outside the cell, you will notice that this is probably pretty much the same size as the neutrophil. So pick your answer. All right. And then next question, which fungal organism will be this one? This picture is not very high quality, but you can still appreciate this round structure that you're seeing. And notice that there is a prominent feature surrounding the structures that there's a clear area surrounding the structures. And that's one of the biggest morphologic feature for this fungal organism. So what is it? All right, I hope you have all your answers. And then we were talking about something that we, some other fungal organisms as well. So this one is Coccidioides, and Coccidioides is quite big. If you're lucky, you will see some granular structure which represent the endospore inside the fungal organism. And you notice that in the background, although it's not super clear, but each of this blurry structure is a neutrophil. So this structure is much bigger than a neutrophil. So here's another picture. This is a teeny tiny neutrophil, and this is the huge coccidioides fungal organism. All right. So we have talked about all the inflammation, and then we will be moving on to talk about neoplasia. And there are three most common type of neoplasia: epithelial, mesenchymal, and round cell tumor. So for epithelial tumor, it's usually well exfoliated. So when you take the sample, it's usually you can get a very highly cellular sample. And the cells in low power, they tend to stay together in clusters, as you can see here in this picture. And then the mesenchymal tumor, the cells are more spindle looking. They're usually poorly exfoliated. So when you take the sample, you usually don't expect to see a highly cellular sample. Cells are more individualized. You're not necessarily want to stay together. And the cells would be more spindle in shape. And also usually you don't see a very clear cytoplasmic border around them. But sometimes if the cellularity is high, you can see cells in aggregates. So kind of like in this area, cells are in loose aggregates. They are close to each other, but not actually having a very cohesive relationship between them. And then this is round cell tumor. Round cell tumor is usually well exfoliated. When you take the sample, you can have a lot of cells. Cells are round, and they're more, sometimes we call them discrete cells, meaning that they're more like by themselves, have very distinct cell border, and they're very individualized. All right, so then I will spend a little bit time to talk about round cell tumor. And I want you to memorize this T length thing with the silent Y. So this would be a very helpful way for you to memorize all the round cell tumors. So starting with T, when we talk about T, then you would think about TBT. When you talk about L, then you would think about lymphoma. M would be mast cell tumor. P would be plasma cell tumor. H would be histiocytoma. So then for each type of round cell tumor, I'm going to talk about 1 or 2 morphologic features that you can memorize for each of them. Starting from TBT, the most common feature of TBT is you see those distinct vacuoles in the cytoplasm. And those vacuoles, sometimes we describe them as punch-out vacuoles, because basically like you take a hole puncture and then you just like to create those vacuoles in the cytoplasm. That's the most significant feature of TBT. For lymphoma, the significant feature would be the cells have a very, very, very high NC ratio. And what does it mean by saying very, very high NC ratio? So if you look at the cell here, look at this one. This one barely has any cytoplasm. So I don't even describe the cytoplasm being small amount of cytoplasm. I would say this is like scant amount of cytoplasm because there is basically no cytoplasm. So very high NC ratio. And then if you compare the size of the cells to a ribosome cell, you will see that the nucleus of a big lymphocyte can fit almost 2 ribosome cells in the nucleus. So that will tells you that most of the cell here in the picture are all large lymphocytes. Occasionally you have these small lymphocytes that are pretty much the same size. It can fit 1 or about like 1 ribosome cells in the nucleus. So that would be the morphologic feature of lymphoma. Moving on to mast cell tumor, obviously mast cells have granules. They have those purple fine to gross granules in the cytoplasm. So this one obviously is a mast cell tumor. Moving on to plasma cell tumor, you will see several features of plasma cell tumor here. The first one is there's always a perinuclear Golgi zone. Not always, but hopefully you can recognize them in the plasma cell tumor. So first of all would be the Golgi zone. And second one, if you look at the nucleus of the plasma cells, you will notice it has this patchy clumped chromatin pattern in the nucleus. And sometimes I describe that as the soccer ball appearance. You have the patchy area and then you have the clear areas. And then you will see binucleated cells as well. So for example, this one is a binucleated cell. This one is another binucleated cell. This one is another binucleated cell. So binucleated cells will be quite often in plasma cells tumor as well. All right. And then there are also other morphology feature of plasma cells. Sometimes they can look pink. And in that case, we call them flame cells. So you can see we have several flame cells in this picture. And then you notice that even though they are in the flame cell morphology, they still have the perinuclear clear zone. They still have Golgi zones. And the nucleus still look very patchy, like a soccer ball appearance. So these features can still help you identify them as plasma cell tumor. And then the last one is histiocytoma. So when we talk about each morphologic feature for different types of round cell tumor, you memorize at least one feature for each of them. And histiocytoma would be the last one that does not have any feature. So it does not have the vacuoles as the TVT, does not have a very high NC ratio because you can see abundant cytoplasm here. So it's not lymphoma. You don't see the granules in the cytoplasm, so this is not mast cell tumor. You don't see the perinuclear Golgi zone. There is no patchy pattern in the nucleus. This is not plasma cell tumor. So usually if you determine this is a round cell tumor, and it does not have any of the above morphologic features, and this is most likely a histiocytoma. And sometimes people describe that as a fried egg appearance. You have the egg white and then you have the egg yolk in the center. Other than that, you have nothing. And that would be the morphologic feature for histiocytoma. All right, then I'm going to spend a little bit more time to talk about some type of mesenchymal tumor. So mesenchymal tumors, some of them look more spindle, some of them look more roundish. The more spindle looking one would be look like this. Cells are more elongated, more wispy looking, have wispy tails. They don't have a distinct cytoplasmic border. So these type of mesenchymal tumor are most commonly associated with soft tissue sarcoma. And there are three specific types of sarcoma under the category of soft tissue sarcoma. We cannot distinguish them on cytology, but sometimes there are some features that can suggest that this would be more likely to be one of these three sarcomas. So for example, if your cell, the cells are really elongated, they're really wispy looking, then they're more likely to be fibrosarcoma. So in my report, cytology report, if I see this type of cells, my interpretation will still be sarcoma. In the comment section, where I'll be saying that this is most likely soft tissue sarcoma. Based on the morphology, I think fibrosarcoma is the most likely one, but I cannot completely exclude the possibility of other types of soft tissue sarcoma. And similarly, this one would be another type of soft tissue sarcoma called perivascular wall tumor. And the reason why this type of morphology is associated with perivascular wall tumor is that you would notice it is more roundish. And it's very common for you to find multi-binucleated cells or multinucleated cells. And they have a morphologic feature of multinuclear cells have their nucleus aligned well at the periphery of the cells. And for this type of cells, we call them crown cell. When I see crown cell, I think this is most likely associated with a perivascular wall tumor. I cannot be 100% certain, but that's has a higher chance to be associated with perivascular wall tumor. Also, there are more roundish mesenchymal tumor. For example, this one is a epithelial hemangiosarcoma. You can notice that the cells, they are still considered as spindle cells because you see the indistinct cell borders. Occasional cells still have the wispy tails, but overall it looks slightly more roundish compared to their really spindle-looking relatives. And then this is osteosarcoma usually have the neoplastic osteoblast. They really look like plasma cells. You will notice that they also have a perivascular clear zone. However, they don't have that patchy chromatin appearance. And there are also some other features you will notice in osteosarcoma. So you will see osteoclast because this is simple, most likely aspirated from the bone. And then you will notice that in the cytoplasm, they have a lot of this purple granules that indicate the osteoid, this bright pink extracellular material that they're making. So you can appreciate their appearance in the cytoplasm. And also osteosarc have a feature of eating red blood cells. So inside the cytoplasm, you can see the phagocytized red blood cells as well. All right. Lastly, we will talk about criteria of malignancy. So if cells fulfill 3 to 4 criteria of malignancy, then we call that malignant neoplasia. So if it's a epithelial tumor, then we call that carcinoma. If it's a mesenchymal tumor, we call that sarcoma. And I try to divide the criteria of malignancy into different categories. So if we're focusing on the cytoplasm, then you can think about some examples. For example, basophilia, the cells look more basophilic, more bluish. Or you can think about like different cells, they have size variation. We call that anisocytosis. Or different cells, they have increased or variable NC ratio that they don't look homogeneous and look very different among each other. Some criteria focusing on the nucleus would be like the difference in nuclear size between different cells. We call that anisokaryosis. And then some ugly cells will have a really big nucleus. We call that karyomegaly. Also, cells can be multinucleated. So multinucleation is also one of the criteria of malignancy. Also, nuclear molding or nuclear spooning. So that's a situation describing a cell has multiple nucleus. You will see that there is one weak nucleus that was being pushed aside by the other big nucleus and kind of making the original round nucleus into a more like the spoon-like morphology. So that's what we call nuclear molding or nuclear spooning. And also nuclear pleomorphism, that the nucleus is not necessarily round. It could look like popcorn. It could be lobulated. It could have all different kinds of morphology that also indicates malignancy. And also weird mitotic figures that, because cells, you see mitotic figures meaning that cells are dividing, but sometimes there are some weird mitotic figure. You just feel like the cell wouldn't make it. It wouldn't make it into 2 different cells. And you will see that very obviously in the following examples. And also we focus on nucleolus as well. So a lot of times, sometimes you're not supposed to see the nucleolus. So when you see prominent or multiple nucleoli, as pointed out here by the arrow, you can see those basophilic round small nucleoli inside the nucleus that indicate malignancy as well. And also those nucleolus can be in different size. So we call that anisonucleosis or anisonucleoliosis. Those 2 terms means the same thing, but they're very long and very complicated. I rarely use them in my reports. All right. So that's have an overview of different types of criteria of malignancy. And I hope that as I talk about them, you try to take a couple of seconds to think about the answer first before seeing my answer. So if we look at the red arrows, comparing these two cells, you notice that one cell is small, the other cell is really big. So that would be size variation among the cell. Yes, that would be anisocytosis. And then focusing on this orange arrows, you see that it points toward the nucleus of two different cells, and there's some size variation among the nuclei. That's called anisokaryosis. And if you focus on this giant cell has many structures inside the cell, how would you describe what's going on? Yes, that's multinucleation. And lastly, we can see this cell here. Inside the cell, there are some fragmented nuclear material. What's going on? Perfect. That's bizarre mitotic figure. This is a weird mitotic figure. You know that the cells are not going to make it to multiple cells, and it's just totally a mess here. All right, now we are going to answer a few more quiz questions. So for this one, my question is, what type of neoplasia is this one? And assuming like we are in low power looking at the overall cell distribution in this neoplasia, is it an epithelial cell? Is it a mesenchymal cell? Is it a round cell, or is it a neuroendocrine cell? All right, pick your answer and we'll move on to the next question. What type of neoplasia is this one? So again, looking at the overall shape of the cells, are they wanted to be together or are they wanted to be by themselves? What are the shape of the cells? That should be able to help you to answer this question. Epithelial, mesenchymal, round cell, or neuroendocrine? Right, perfect. What type of neoplasia is this one? And I showed you the picture before, but I was focusing on the lymphocytes pointed by the arrow. But now what I want you to do is to ignore the lymphocyte and the arrows, only focusing on the other cells, the neoplastic cells surrounding the lymphocytes. So what type of round cell is this one? And think about the morphologic feature for each type of the cells and pick the right answer for that. All right. Moving on to question number 8, also asking what type of neoplasia is this one? And I provide you a little bit more additional information. So this is an epidermal dermal mass at the medial aspect of the left carpus in a 10-year-old French bulldog. So this is a nodule, and this is how the cytology look like. So based on the cytology, what type of round cell tumor is this one? All right, if you don't have enough time to answer the question, you can pause the video to pick the right answer and then move on to the next question. All right. So this is a lymph node cytology in a 5-year-old golden retriever. What type of neoplasia is this one? So this is taken from the lymph node. And you notice that the answers are a little bit different. I have A, lymphoma, B, mast cell tumor, C, neutrophilic inflammation, and D, there's no cytologic abnormalities. So there is only one correct answer, and pick the right answer from these options. All right, then moving on to the last question, which is a bonus question. Is it inflammation or is it neoplasia? So this is a fine needle aspirate from the right anal sac thickening in the 12-year-old female spayed Shih Tzu. And we don't have a definitive answer for this one, but in my cytologic interpretation, I did make my choice. So do you think this is inflammation or do you think this is neoplasia? Pick your answer. And this is just a bonus question, so I would not take this question into the consideration. But I will look at your answer for the previous 9 questions and take that into account. All right, if you answered this question and that's all for today, please complete your other assignments for the cytology review. And that's all about the approach to cytology. If you have any questions, just let me know. I will be happy to answer them for you. Thank you.